This is Dr. Julie Huffmeyer with our open anesthesia intraoperative TEE case of the month for November 2011. Each month we feature an operative case which teaches or emphasizes an important aspect of basic intraoperative TEE. As you may remember from our October 2011 podcast, we reviewed the pathophysiology of aortic stenosis and the basic TEE views used in the operating room to look at the aortic valve. In Part 2 this month, we will discuss the quantitative evaluation of aortic stenosis with TEE. To review, the case involves a 78-year-old man who presents with worsening dyspnea and angina over the past several months. He has been in good physical condition prior to this time, able to play tennis and exert himself physically. When he was seen at his primary care physician's office, he was found to have a murmur consistent with aortic stenosis. He was referred to a cardiologist for a workup for aortic stenosis. A transthoracic echocardiogram showed a preserved ejection fraction, but severe aortic stenosis with an aortic valve area of 0.7 centimeters squared and a cardiac catheterization which revealed non-obstructive coronary artery disease. He is coming to the operating room for an aortic valve replacement. TEE is an excellent tool to evaluate the severity and cardiac consequences of a long-standing valvular disease such as aortic stenosis. There are multiple echocardiographic views used to image the aortic valve. It is important to take note of the morphology of the aortic valve and to evaluate it from multiple angles and views. This is a review slide from last month's podcast. It is the mid-esophageal aortic valve short-axis view at approximately 40 degrees multiplane angle. The left atrium, and right ventricle are labeled. The aortic valve is seen in cross-section. The valve appears to be trileaflet, and there is a significant amount of echo-bright white calcium deposit that is visualized on the aortic valve leaflets. Reduced mobility and excursion of the leaflets are noted. A very small aortic valve opening is seen during systole. This is another TEE from October 2011 to review the mid-esophageal aortic valve long-axis view. It is most commonly found at approximately 120 degree multiplane angle. For our patient, this image was best found at 140 degrees in order to see the left atrium, left ventricle, stenotic aortic valve, and the aortic root. Again, the aortic valve leaflets appear to have significantly reduced mobility, and calcification is easily noted on the leaflets. Two-dimensional echocardiography in the mid-esophageal aortic valve short-axis view at approximately 45 degree multiplane angle allows the aortic valve orifice to be seen and measured or traced. This is called planimetry. For planimetry to be accurate, it is important to identify the actual minimal orifice. It is easy to be either superior or inferior to the actual cross-section of the aortic valve. All three leaflets of the aortic valve must be seen. The depth and view can be optimized by using color flow Doppler to identify the correct depth of the valve leaflets, the leaflet edges, and the most narrow portion of the valve orifice. It is also important to minimize the gain settings, otherwise valve area may be underestimated due to the brightness seen due to the thickened calcified valve leaflets. Once the best view is obtained, the image is frozen in systole, and the electronic tracing caliper of the TEE machine is used to trace the opening and obtain an area. The use of planimetry is limited by the inability to determine if the actual minimal orifice is being imaged, and TEE is not as accurate if the valve is heavily calcified, which is normally the case with severe aortic stenosis. Some studies have shown that planimetry of the aortic valve area compares favorably with measurements of aortic valve area obtained by cardiac catheterization. This is the planimetry of our patient's aortic valve in short axis as described above. The image is frozen in systole, when the aortic valve should be open to its maximal orifice to allow the ejection of blood flow. Appreciate the very small, irregular stenotic orifice. This planimetry method is difficult to perform accurately, as the bright white calcium artifact can cause underestimation of the true orifice of the valve. Planimetry in this patient measured an aortic valve area of 0.6 centimeters squared. The severity of aortic stenosis can be measured quantitatively via TEE using Doppler echocardiography. A thorough review of Doppler principles and their use in echocardiography is beyond the scope of this podcast. Quantitative Doppler assessment can be done in two ways: by placing the Doppler beam across the aortic valve and measuring the gradient across the valve with the modified Bernoulli equation, or by estimating the aortic valve area with the continuity equation. For both of these techniques, it is vital to align the TEE transducer beam parallel to the flow of blood through the left ventricular outflow tract and aortic valve. Otherwise, the angle of incidence will introduce significant error into the measurement. The two locations to align the Doppler beam most parallel with the flow of blood through the aortic valve are the deep transgastric long axis view, found by advancing the TEE probe deeper from the short axis mid-papillary view, and then antiflexing the probe and withdrawing it slightly, and the transgastric long axis view, found by rotating the multiplane angle to 120 to 140 degrees from the transgastric mid-papillary short axis view. Any probe adjustments must be done carefully, slowly, and gently to avoid injury to the stomach and esophagus. These views can be challenging to obtain and require practice and small adjustments to get the best image possible. This is the deep transgastric view and is found by advancing the TEE probe deeper from the transgastric short axis mid-papillary view and then antiflexing the probe and withdrawing it slightly. Again, the left atrium, left ventricle, and aorta are labeled. This view allows the Doppler beam to be aligned parallel with the flow of blood, thus eliminating error of measurement due to angle of incidence. There are several ways to use the Bernoulli equation in order to calculate transvalvular aortic pressure gradients. The simplified Bernoulli equation states that the peak instantaneous gradient is 4 times the square of the peak jet velocity across the aortic valve. The mean gradient, however, tends to correlate well with invasively determined gradients, but it is vital to have the true peak aortic velocity for the mean gradient determination. Thus, it is important to get the best blood flow across the aortic valve. You can tell this by getting a smooth envelope when using the Doppler beam. The mean gradient is obtained by averaging instantaneous gradients over time. Once the Doppler beam is lined up, the aortic velocity profile is traced, and the computer software calculates the mean gradient. Otherwise, the mean gradient can be estimated from the peak gradient, as the mean gradient is 2.4 times the square of the peak aortic velocity. The peak gradients obtained can be influenced by the blood flow on the ventricular side of the aortic valve. The simplified Bernoulli equation ignores this component, and with isolated aortic stenosis, it is usually okay to ignore this. When the left ventricular outflow tract blood flow exceeds 1.5 meters per second, such as in cases of aortic insufficiency, this must be factored into the Bernoulli equation in order to avoid overestimating the pressure gradient. In these situations, the gradient is calculated as 4 times the quantity of the square of the peak aortic velocity minus the square of the left ventricular outflow tract velocity. This is an example of the flow profile obtained when the continuous wave Doppler beam is aligned with the flow of blood exiting the left ventricular outflow tract through the aortic valve into the aorta. This is again the deep transgastric view. The velocity scale is seen along the right side of this image, and from an initial view, the greatest velocity noted here is approximately 400 centimeters per second, consistent with severe aortic stenosis. This is the computerized velocity profile tracing of the same waveform. There is much information obtained once the blood flow velocity profile is traced. The maximal velocity traced is 409 centimeters per second. The maximum pressure gradient is 67 millimeters of mercury, and the mean pressure gradient is 31 millimeters of mercury. In order to calculate the aortic valve area via the continuity equation, the volume of blood that flows across the left ventricular outflow tract must be known. This is referred to as volumetric flow. This first step toward calculating aortic valve area is accomplished using Doppler technology in order to determine stroke volume that flows through the cylindrical structures of the left ventricular outflow tract and aorta. The spectral display that is generated allows integration of Doppler-derived flow velocities with respect to time, which is known as the velocity time integral, or VTI. Tracing of this flow pattern allows calculation of the VTI. This gives a stroke distance in centimeters, so this is the distance that the column of blood flows in one cardiac cycle. Then stroke distance is multiplied by the cross-sectional area of the cylinder or left ventricular outflow tract to give stroke volume. The principle of the continuity equation is that the volume of blood that goes into the stenotic aortic valve is equal to the volume of blood that leaves the aortic valve. Once stroke volume of blood from the left ventricular outflow tract entering the aortic valve is calculated, and the velocity of blood is measured as it exits the aortic valve, the equation can be rearranged to discover the area of the aortic valve. First, the cross-sectional area of the left ventricular outflow tract must be calculated as pi r squared. This is accomplished by measuring with the electronic caliper the diameter of the left ventricular outflow tract at the insertion of the aortic valve leaflets in the mid-esophageal aortic valve long axis view at 120 degrees multiplane angle. This diameter is halved and then used as the radius measurement in the cross-sectional area equation. The normal diameter is approximately 2 plus or minus 0.2 centimeters, varying with body surface area. Pulse wave Doppler allows the echocardiographer to choose the location of the sample volume. The cursor is placed at the same place that the radius was measured. This is close to the aortic annulus within the left ventricular outflow tract. The velocity profile is traced with the electronic tracing caliper to measure the left ventricular outflow tract VTI. Continuous wave Doppler is used to sample the volume at the point of highest velocity within the left ventricular outflow tract and aorta, which in patients with aortic stenosis should be at the level of the stenotic aortic valve. Again, the velocity profile is traced to measure the aortic valve VTI. This is the diameter of the left ventricular outflow tract in the mid-esophageal aortic valve long axis view, measured to be 1.94 centimeters. So the radius is 0.97 centimeters. To obtain the cross-sectional area, the radius is squared and multiplied by pi. Thus, the cross-sectional area of the left ventricular outflow tract is 2.95 centimeters squared. This is the VTI at the left ventricular outflow tract, using pulse wave Doppler in the deep transgastric view to obtain the stroke distance. Here, this VTI, or stroke distance, is measured as 24.8 centimeters. This is the VTI at the level of the aortic valve, again in the deep transgastric view, using continuous wave Doppler, which samples at the highest velocity along the Doppler beam. The stroke distance, or VTI, here is 110 centimeters. So, to review, the continuity equation states that the stroke volume from the left ventricular outflow tract entering the stenotic aortic valve is equal to the stroke volume exiting the aortic valve into the aorta. Stroke volume, again, is the cross-sectional area of the cylinder or the left ventricular outflow tract multiplied by the velocity with respect to time, which is the stroke distance. Then the equations are set equal to one another and solved for the area of the aortic valve. The area of the aortic valve is equal to the stroke volume of the left ventricular outflow tract divided by the velocity time integral or stroke distance at the aortic valve. For our patient, his aortic valve area is calculated to be 0.67 centimeters squared. This table shows the different measurements available to classify aortic stenosis into mild, moderate, and severe. Hemodynamically significant aortic stenosis is a peak velocity greater than 4 meters per second with a mean gradient greater than 40 millimeters of mercury and an aortic valve area less than 1.0 centimeters squared. It is important to remember that calculated aortic valve areas and gradients are based on hydraulic principles and the assumption that the patient has preserved left ventricular function and a good cardiac output. Patients who have impaired left ventricular function may not be able to generate this amount of pressure to overcome a severely stenotic aortic valve, yet their aortic stenosis may be severe or even critical, and thus other methods of evaluation of the valve must be used. In future podcasts, aortic stenosis will be reviewed for the patient with impaired left ventricular function. Our patient has a peak velocity in the severe category, but a mean gradient in the moderate category. With his preserved left ventricular ejection fraction, his aortic valve area is calculated to be 0.67 centimeters squared, thus placing him in the severe aortic stenosis category. In summary, aortic stenosis is a common indication for cardiac surgery and valve replacement in patients older than 65 years of age. TEE is a very useful tool to quantitatively evaluate aortic stenosis via both the Bernoulli equation and the continuity equation. The combination of peak gradient, mean gradient, and aortic valve area, in addition to clinical data, allow the anesthesiologist and echocardiographer to better understand aortic stenosis and the left ventricular function.